Hello, everyone. My name is Audrey Cooper. I'm the editor-in-chief of WNYC, and I wanted to thank you all for joining us today. It's my privilege to head a newsroom with an incredibly impressive team of healthcare reporters. They've each gone above and beyond in their service to our listeners by providing unflagging coverage of the pandemic, healthcare, climate change, and so much more. And I'm especially grateful to our fearless editor on this team, a man who's not only a great journalist, but a great scientist, Dr. Nsikan Akpan. Now, we're pleased to have the opportunity to hold this health convening each year thanks to our longstanding partnership with the Alfred P. Sloan Foundation and Doran Weber, Vice President of Programs. In addition, we're very grateful to have such distinguished panelists with us today, including healthcare economists, practitioners, and policy experts. These are the people who are working to find solutions to the healthcare challenges of our times. Now, I expect that today's conversation is going to generate a range of news ideas for our reporting about the effects of the COVID pandemic, from its impact on the healthcare workforce to the effects of long COVID on employment. And we also plan to explore another public health crisis, the drug overdose epidemic, which is an increasingly serious topic, but one that has received less national attention due to the ongoing COVID pandemic. I'd also like to acknowledge the Robert Wood Johnson Foundation, whose support, in addition to the Sloan Foundation, has been so vital in enabling us to produce healthcare coverage of this consistently high caliber. And thanks especially to Jordan Reese. We look forward to sharing with our audiences what we learned today, because the more informed our listeners and readers are, the more they can advocate for the healthcare needs of their families and their communities. So next, I'll stop talking and I would love to introduce Doran Weber, who's been instrumental in making today possible. Doran, over to you.
Hey, everybody. I had to get that technology to work. We're a technology foundation, so we're obviously having trouble with the tech. It's a pleasure to be here. None of us foresaw the pandemic. I remember when Laura Walker came to me with this idea, 10 years ago, I think, to start a healthcare reporting unit, but we all understood this was in the wake of Obamacare, and we were concerned about explaining Obamacare to the public and what it meant to people in their everyday lives. But Laura had the insight, and I think now widely shared, that it was a matter of everybody's life is affected by healthcare. And of course, the pandemic is a case in point and so I'm looking forward to this discussion today. My role here generally is just to tell you a little bit about the Sloan Foundation briefly. For those of you who don't know us, we're a nonprofit philanthropy founded in 1934. We make grants for research and education in science, technology, and economics. And this program is part of our public understanding of science technology effort. We support books, things like Hidden Figures, big success of ours, Elizabeth Colbert's Under a White Sky. Right now, a book called Vagina Obscura is getting a lot of heat, demystifying female anatomy for women as well as men. We're big supporters of public radio. We were founding sponsors of Radiolab. We're longtime supporters of Science Friday, Planet Money. We have a couple of new shows, How to Fix the Internet with EFF and The Lost Women of Science. And we're also big fans and supporters of Gastropod, big television supporters in terms of COVID, a number of things that might be of interest to you. If you don't know them already, How to Survive a Pandemic by David France, which came out recently, and Extra Life with Stephen Johnson, which looked at 200 years of advances in public health juxtaposed with COVID pandemic. We're also big supporters of film, support a dozen film schools, give annual awards in screenwriting and film production for scripts that have science, and we support Sundance, Tribeca Film Independent, and screenplay development programs. And we have a big theater program right now. Golden Shield is on Manhattan Theater Club, and we have a play called Semmelweis about the pioneer of hand washing, who was drummed out of the medical profession with Mark Rylance, that was at the Bristol Old Vic, and we're hoping to bring to the West End and maybe to Broadway next year. So very wide range. We're like a nonprofit multimedia company for science, but nothing could be more important than what we're doing here today. So I'm looking forward to this conversation. And now thank you all for coming, and let me hand it back to, is it Audrey or?
Hey, I think it's me.
Oh, you here. Let me mute myself.
Thanks everybody for coming. I'm Nsikan Akpan. I'm the Health and Science Editor for WNYC. And I am also the host of our first panel, which is about should you tell your employer that you have COVID-19 or that you have long COVID, excuse me. At the top, I want to give a big thank you to Sloan Foundation for supporting this health convening. I also want to thank the Robert Wood Johnson Foundation for supporting our health coverage in general. And one production note at the top, feel free to drop questions using the Q&A function at the bottom. We'll try to answer them as we go along. So our panel today consists of Maanasa Kona. She is an assistant research professor at the Center on Health Insurance Reforms at Georgetown University. Her research focuses on the federal and state level regulation of private health insurance markets in a post-ACA era and its impact on consumers. In addition to her research and writing, she also advises state and federal regulators and legislators on a variety of private health insurance policy issues, helping them understand the options available to them. Our other panelist is Karyn Bishof. She's the founder and president of the COVID-19 Longhauler Advocacy Project, a nonprofit whose mission is to advance the understanding of long COVID and expedite solutions and assistance for long haulers through advocacy, education, research, and support. Karyn has a bachelor's of science in exercise science and health promotion, was a firefighter/paramedic when infected with COVID-19 in March 2020, sits on the advisory board of the Long COVID Research Fund, and serves on an oversight committee for the National Institutes of Health Recover Initiative, a nationwide study into long COVID, and is a single mom trying to navigate being newly disabled. And so Karyn, I want to start there. Do you want to briefly walk us through what your experience with getting care for long COVID has been like?
Sure. So, as you mentioned, I got COVID-19 very early on in the pandemic. In March 2020, nobody was aware of long COVID, and a lot of people really weren't aware of long COVID probably until that summer. So finding care in the beginning was really hard because everyone just had this conception of you get COVID and you get better, or you get COVID and you die. And nobody was considering that middle ground of post-viral illness, which many people are very well aware of. And we didn't count that for the COVID-19 pandemic. So seeking care in the beginning was hard because I was being told, well, you're not positive for COVID-19 anymore, you're fine, move on. So it wasn't until long COVID really started getting some national attention and some of us banded together that long COVID started getting more attention. There were other advocacy organizations for chronic illnesses like dysautonomia and MECFS and some autoimmune conditions that were reaching out to us saying, hey, you guys look like us. You guys look, you have so many symptoms of dysautonomia. You have so many symptoms of MECFS. So that helped start us on the right direction. Unfortunately, long COVID is this collection of post-viral illnesses, some of which I just mentioned. So it takes going to multiple doctors and kind of getting ping-ponged around, trying to, one, find somebody who's up to date and knowledgeable on long COVID. Two, finding somebody who knows how to treat these conditions, right? That doesn't necessarily have a lot of interest in their fields or a lot of training for people to practice. And it's very hard for people to, get into these appointments. So over 27 months now of me being sick, I've seen 40 different doctors. I've been diagnosed with numerous health conditions that I'll now have likely for the rest of my life until research proves otherwise or gives some better treatments. And it's a constant battle because everyone likes to practice only within their specialty, but long COVID demands comprehensive care, systemic care. So that causes us to have to go to more doctors. Therefore, kind of the snowball effect of increasing prices and increasing the amount of energy and spoons that it takes for chronic illness patients to get to so many doctors and manage this type of care. So it's been a roller coaster. It's been very hard.
Yeah, when we spoke earlier, you kind of laid out 3 steps that people need to know to sort of get care. So, identifying the right provider in terms of like the right doctor, getting your condition documented, and figuring out treatment. Do you want to talk a little bit about the importance of each step?
So the first part requires people to recognize that they have long COVID, right? There's so many people who are dealing with these lingering health issues. And we know that you can have long COVID after an asymptomatic infection. You can develop long COVID, even after vaccination. So when people develop these new health issues, they might not immediately relate it back to their COVID-19 infection, especially if they didn't know they were infected and had an asymptomatic case. So what we've been lacking the entire pandemic is national public education and awareness campaigns. So we need to let people know that this is a potential, right? Then help them identify this issue and then seek care for it. So that's the first part, is seeking care for it, and then finding a provider that has experience identifying long COVID, that's trying to stay up on the recent research and the guidelines, which is ever evolving every week at this point. And ensuring that this provider is then documenting your conditions correctly. So making sure that they're using the U09.9 code to document long COVID, even if they're diagnosing you with a form of dysautonomia, and they believe and you believe that that's a result of your COVID infection, they should be using that code along with whatever other condition they're diagnosing you with. So you want to make sure that that's documented, because then that plays a role in you finding treatment, right? So right now, insurance companies are giving patients and providers a really hard time when they're trying to get, different types of medication, because there is no real protocol for long COVID yet in the insurance world and in the provider world. So patients are getting medications through the conditions they're being diagnosed with, like dysautonomia and ME/CFS and MCAS. But we also have to remember that these conditions are very specialized, and we need every single primary care provider in this country to be able to at least identify long COVID and its associated conditions, so that they can help their patients get to the right specialists. But more so, at the same time, we need more people, more physicians to become interested in these fields, because we now have 20 to 40 million Americans joining these chronic illness communities who already didn't have enough doctors, who are already waiting 12 to 18 months for appointments. So what we need is more interest and more funding for these fields to provide the care we need for the now millions influx due to long COVID.
Absolutely. And then Maanasa, I want to spin off of that, and I want to, break out the three steps a little bit more. And, we got a question ahead of the session from a Katrina Corbell. She said, it took months of inserting myself with top docs at some local hospitals here in the city to sort of say, like, hey, I have post-COVID, like, hey, I'm a long hauler, and she says, we're still hearing from peers around the country whose doctors turn, I don't knows into misdiagnoses instead of referrals to legit post-COVID clinics. And she's asking, how can we hold doctors more accountable while also supporting peers as they enter, 2 to 5 year periods of applying for disability assistance? But the question I want to ask you is, because I feel like this journey sort of starts with a 2-word term called medical necessity. And I think it's something that long COVID patients and their family members should need to remember when they work with doctors. Can you define what medical necessity is for the audience and explain how it factors into getting health insurance to pay for chronic care for conditions like long COVID?
Sure. So generally speaking, health insurance plans tend to automatically pay for claims for familiar and frequently used tests, treatments, procedures for common conditions, but then they tend to apply more scrutiny for less common or familiar services or diagnoses. And for these less common and familiar diagnoses, a plan can choose to accept the treating clinician's judgment and pay the claim, or they can determine that the service is not medically necessary and then deny the claim. The plan definitions for what medical necessity is generally vary, but they are usually tied to scientific evidence and professional standards of practice. And then based on this evidence and standards, plans either develop their own treatment guidelines for determining medical necessity, or they rely on guidelines that develop by external groups like physician organizations. A thing to note is that many plans tend to exclude coverage of unproven therapies outside of official clinical trials. And then without evidence of effectiveness of a particular treatment, plans are likely to choose not to pay for it. In terms of long COVID, patients facing medical necessity denials do have a couple of options. If the health plan is refusing to pay for some aspect of the treatment based on medical necessity, patients do have the ability to appeal this decision. So they can perhaps submit any additional information from their provider and explain why they need this disputed service. The plan in turn will internally consult with their clinical experts and see if they think that these services that are under dispute are indeed medically necessary based on the new evidence or new arguments that have been submitted. If the plan then denies the internal appeal, patients can also request an external or independent review, and this is usually with the state regulator. That will involve, again, a clinical expert evaluating whether the service or care in question is medically necessary. So depending on what kind of insurance you have, patients may have the right for even further appeals beyond this external appeal step. For example, Medicare Advantage enrollees do have access to multiple appeals beyond this stage. But in order for patients to get the coverage they need, it is first extremely important for the clinical research world to collect the right clinical data, scientifically establish the evidence for the various treatment options. And then it's up to the treating physicians, like Karyn said, to remain abreast of the latest developments and scientific evidence and to make that case to insurers on behalf of their patients, because they're the ones who are probably more likely to have all of the information and to be able to present information in a way that insurers can take it in and accept it. Physician associations and organizations can also play a huge role in ensuring that the emerging evidence is reaching both physicians on the ground as well as the insurers.
And then, in terms of making sure that, insurers are getting the right information, that, researchers who are looking into this are getting the right information, one of the first steps in that is making sure that the doctors enter a special code for long COVID, U0909. Or sorry, U099. Karyn, you mentioned this a second ago. This question is for either of you. Why is that process important, if we're talking about getting coverage or just like studying this condition or this series of conditions?
I mean, I would start with talking about it from a research perspective, right? Like, for example, we have research studies right now that are combing electronic health reports, trying to look for this code and identify long haulers for studies, trying to look for the codes for dysautonomias and ME/CFS and MCAS and all these associated conditions to identify long haulers. And some of this data also goes towards being reviewed by, places like HHS or the White House, who are trying to see how many people are seeking care for long COVID, what does the disability rate look like, and so on and so forth. So from a research perspective and moving towards creating or expanding some of the social supports we need when they're talking about what are the numbers, this is one of the ways that they do that. And then the other aspect is, what conditions are long haulers developing? Where do we focus our research money on? What do we know about those current conditions? Do we expand on existing research? Do we start from scratch? And so on and so forth. And what we've been encouraging researchers is to not start from scratch, because it's very clear that many of the conditions we're developing are these collections of post-viral illnesses, that we've seen in the past. We just have not put the time and effort and money into trying to understand them. And I think one of the biggest focuses we have to have is knowing that if we do nothing, we will be like this for the rest of our lives. We need that research to happen. So doctors must be able to screen for long COVID, right? If you're not asking, you're not going to identify it. So ask your patients, use some of the screening protocols, use this code, input this code so that we can start learning more about the numbers, because long COVID is not being formally counted. And right now, this is the only way that we have a way of counting it. And it's only been around since fall 2021. So there was a whole year and a half prior to this code existing of people seeking care where this code wasn't used. So I would even say, if you're a patient who sought care early on, go back to these doctors and ask them and make sure that this code is now part of your medical records, because at that time it might not have been. You want this code in there now.
Right, exactly. And I mean, we're also talking about millions of people, right? I think, most of the studies out there are seeing about 20 to 30% of people who catch the coronavirus end up developing some type of long COVID. And when when you run the numbers, that will eventually make long COVID, if not already, like one of the most prominent chronic diseases in our country. But for all those patients, what will go into proving medical necessity? And this question is kind of open up for the both of you. Do patients need to head to their doctor's office with studies they've printed out, being like, look, like I have these symptoms right here? Or do doctors or employers need to advocate for on the behalf of their employees to health insurance companies, being like, no, I think my employees are really struggling here and they need, some of these benefits? Like, what kind of goes into kind of the proving the medical need for these things? And it's for the both of you.
I mean, I would say one of the biggest things that would help probably the most amount of long haulers is having more national guidance come out for providers and for insurance companies. Because yes, right now you have patients that are following the research and printing out articles to inform their providers, because there's currently no mandate for providers to stay abreast of long COVID research. And therefore, we believe there should be, and this should be part of like CEUs or CMEs for providers because of the prevalence of long COVID. They're guaranteed to now see this in their patients, right? We have anywhere from 3 to 5 out of every 10 developing long COVID. So of course, these providers are going to see it. They have to make it a priority to stay on top of it. And we can't depend on sick patients to read through pages and pages of research, but they do depend on groups like ours to be able to provide them that information and say, yes, this is a credible source, or you guys should be checking out this clinic, or you have this doctor in your area, or here's a valuable research study that we think you should be involved in. So for a patient to go to their provider and provide medical records helps give them credibility into what they're saying. A lot of doctors are up for seeing peer-reviewed research in order to order certain tests or try some new medications. But again, it goes above the doctor's head to the insurance companies, which I don't think is the same ballgame of just handing them research articles. Now, that's where you need your doctor to partner with you and go to bat with you, right? But it would be much more helpful to have more national, federal, or even state mandated oversight or guidelines that come out saying, here's what we're seeing in long COVID patients. Here's what we should be expanding coverage to. Here's what we should be considering for this population. So until that happens, it is on the patients and the providers.
I will add one point though. You mentioned employers, and I think employers do have an opportunity here, particularly with respect to those patients who are enrolled in insurance through their employer. They contract with these insurers to be third-party administrators, to be either fully insured health insurance products to provide them to their employees. And they have leverage on the basis of those contracts. They tend to be a big chunk of their business, and they want to work with employers. Insurers want to work with employers. So, when employers are dealing with so many employees who are either unable to return to work because of brain fog or fatigue or whatever, they should be motivated to lean on the insurers that they're contracting with to ensure that their employees are getting the care that they need. So there is an opportunity here, but of course, and not all employers will be this motivated to work for their employees.
Right. And then, I feel like another issue at play here is, if you're going to your family doctor, if you're going to like a general practitioner, they might not know how to spot this. They might not know the signs, right? Like we're still sort of understanding how post-COVID expresses itself. But we do know that there are some very particular and very severe diseases or conditions that are associated with post-COVID. I'm thinking about, issues with the heart, issues with the liver. Like we are seeing some very, I guess, specialty conditions. So Karyn, do you want to speak a little bit about the importance of seeing a specialist versus, say, like a general practitioner, and maybe the importance of getting to them quickly within your sort of disease, I guess, prognosis or disease course?
Sure. So this kind of feeds off of what I was saying before in terms of every primary care provider in the country needs to get to a level where they can screen a patient and identify long COVID or its associated conditions, because the delay in a provider recognizing that and giving you the referral that many likely need to get to that specialist causes harm to the patient, not to mention current wait times being anywhere from 6 months to 18 months for some of the specialists that need to be seen. And that wait time and those issues are only going to get worse as more and more long haulers are created, because this pandemic is not going anywhere. We will be dealing with this for years, and that's why it's one of the reasons why it's so important to highlight the consequences of a COVID-19 infection and what it can cause. So for you to see a specialist, for example, if I go to my primary who's not aware of, let's say, dysautonomia, right? I'm going to tell them, I'm having like heart palpitations. Every time I'm standing up, I have this horrible tachycardia. I get nauseous. I get these tremors. I feel dizzy, like I'm going to pass out. They're going to tell me something like it's anxiety, it's psychosomatic. And I can't tell you how many people in the long COVID community have heard this. And it has been so damaging to their future medical care, because a provider sees that on their list and thinks, oh, okay, that's what it is. And they don't really investigate. And that is very harmful to the patient. And in addition to dealing with chronic illness, they now are adding to, the depression aspect of being chronically ill and going to a provider for help, and their providers basically telling them there's nothing wrong with them, but it's because they're not educated on the condition. So we really need education for our providers so that they can recognize these and get us to the right people, or manage our care in the interim, right? A primary can start a patient on a beta blocker if they find that they have postural orthostatic tachycardia via a stand test in their office for 10 minutes, right? They don't need a big fancy tilt table test, even though that's like the golden standard, right? But they can do that in their office and try to manage symptoms while that patient's waiting 6 months to 18 months to see that specialist. So there's a very important role for primary care providers in long COVID. They might be the actual most important people for long haulers, because they are responsible for getting us to the right people.
Mm-hmm. And when it comes to long wait times, Maanasa, we're talking about six months, 18 months. I mean, that's a long time to see a doctor especially if you're really sick. But there are also standards in place that healthcare providers are supposed to follow when it comes to wait times. Can you describe how network advocacy standards come into play here?
I will clarify that these standards apply to insurers. So insurers, all healthcare insurers are generally required to have provider networks that are considered adequate, where patients don't have to either travel unreasonable distances or wait like an unreasonable amount of time to get access to care. So this is an onus placed on healthcare plans to make sure that their networks are robust. There isn't one national standard for network adequacy, and the standards tend to vary pretty widely depending on which state you're in, what type of insurance coverage you have. So depending on whether you have an ACA marketplace plan or a Medicare Advantage plan or Medicaid MCO plan. When standards are in place, they tend to be limits on, say, how far the doctor or the facility is, or how long the wait time for an appointment is, or there might be a minimum provider to enrollee ratio for a given area. And depending on the type of plan or the state that you're in, I would personally recommend reaching out to the regulator of your insurance plan, and that can be your state Department of Insurance or your state Medicaid agency, to better understand their rights and see what the regulator might be able to do for you. But it's important to point out that while these standards do exist, it's not perfect, obviously, because like Karyn was saying, there is a lack of, say, primary care providers, and there's a lack of certain kinds of specialists. And so there are ways and exceptions built into these standards to kind of ensure that, that insurers can still like pass the standard, but they don't necessarily have like, they're not really meeting it to the word. And so it's a work in progress. The administration, the Biden administration has strengthened the network adequacy requirements related to qualified health plans. So they're the plans that are sold on the ACA marketplace very recently, and other states are kind of looking into this, strengthening these standards further too, but it's 100% a work in progress. And a lot of this depends on patients, filing those complaints with their state Department of Insurance, because they need that kind of evidence to then go after insurers and be like, hey, why are you not including more of a certain type of provider in your network?
Mm-hmm. Perfect. And then, we have a question that we got from an audience member, and I want to remind people, if you have questions about, how long COVID might relate to reporting or your own lives, feel free to put them in put them in or submit them using the Q&A function. So this question came from a Janae Wright Underwood. She wants us to discuss how long haul COVID is expected to affect disability, and as a result, medical claims, access, Social Security disability, workforces, those types of things. I wonder if either of you would be down to comment on that.
So long COVID presents a really unique opportunity, and now is the time for disability laws and policy to change. There are organizations coming together to try and make this happen. And for long COVID, I'll just speak about one of our prior work that we did back in January, that landed us our meetings with the White House COVID response team and various divisions of HHS and the Department of Labor. Was we found that 44% of long haulers were out of work completely, with 67% being out of work for over a year. And we also found that 51% were reduced to part-time work, with 63% for over a year. 41% said they had already filed for or were preparing to file for Social Security disability.
Wow.
And these numbers are dramatic. The Social Security disability system cannot handle this influx of patients. The Social Security disability has a backlog of over 1 million applications right now. Granted, that's not just long COVID, but it goes to show you that people who are completely without resources, dependent on Social Security disability for any type of income, are going to be waiting even longer than the typical disability process because of the pure number coming in. And of course, this influx of this number is also related to the millions of long haulers who have now unfortunately become disabled. So this process is going to absolutely have to change. The long COVID community is desperately trying to work with the Social Security Administration. We're hearing whispers of, there's discussions happening, but we don't know what those discussions are. We don't have a seat at the table. It's one of the things that we've been asking for them to involve patients in the decision-making and in the planning of these types of things. But right now, we're just wishing and hopeful with no clear decisions. And for people without resources, that absolutely is not helping any situation that they're in right now.
And then Professor Kona, I have another side question, just something that's like come up in reporting. Do we have a sense of how, the I guess sort of the pullback on pandemic funding might affect some of the expanded benefits, expanded resources that, health insurers, healthcare providers were getting, and how that might affect treating COVID, whether it's acute or long COVID, sort of going forward?
Yeah, I think one of the things that we are most concerned about is the rollback of the American Rescue Plan subsidies, the premium subsidies. It was a huge help for people to get coverage and stay covered, and then to be able to afford their coverage, which is so critical in accessing healthcare in this country. And they're supposed to sunset at the end of the year, and that is going to result in a lot of problems and people falling out of coverage. And additionally, also the end of the public health emergency period with respect to Medicaid is going to result in, Medicaid, you're supposed to do eligibility redeterminations to make sure people are still eligible for Medicaid periodically. They kind of put a pause to that during the public health emergency period because they didn't want people to be churning in and out of Medicaid. So they kind of put a stop to that. And once the public health emergency ends, Medicaid agencies will be resuming those redeterminations, which means a lot of people might end up getting pushed out of Medicaid and then potentially being pushed towards marketplace plans where they don't have these additional subsidies that were there with ARPA. So just in terms of just coverage, there are a lot of issues that are coming to the fore, and we're significantly, like, we're worried about that, but and working with the administration to ensure that there is a soft landing for people who might be pushed out of Medicaid. And then, of course, the drying up of funds for a variety of COVID testing and treatment options is also something that is of concern, and it's very important to keep, to renew that funding for the providers who are treating people for COVID and long COVID.
And we just have a couple of minutes left and just a couple of questions left. And I want to wrap up. The third part of this long COVID journey is treatment. We've sort of touched on this. Long COVID really is, it's looking kind of like a spectrum of conditions, but they may not have their own specified treatment yet. Doctors might need to prescribe things off-label, like heart, like even known heart medications for the heart conditions that people are experiencing. Karyn, what's this process like for patients, like trying to nail down those treatments?
Well, I think the first thing is, since a lot of these doctors are not aware of these long COVID associated conditions, right? Like the dysautonomias and ME/CFS and MCAS, that a lot of patients are going to them trying to present them with, like, look, these are the tests that need to be done. These are the medications that I need. The barrier comes because these treatments are not for long COVID, they're for the dysautonomia, they're for the ME/CFS, or they're for MCAS, or whatever the long COVID patients' conditions are. And part of what they need to do is make sure that they're being diagnosed with the right conditions and those conditions to get some of those medications, right? So for example, there's a lot of long haulers that will say, I have this uncontrollable tachycardia, but in reality, they've developed POTS. So the treatment for POTS would be taking beta blockers, right? So for your physician to prescribe you beta blockers, they need that billing code for what they're diagnosing you with. So this is where it comes into providers understanding what conditions are contributing or making up each patient's basket of long COVID, if you will, because while these three conditions I keep naming are the most common, there are many others like fibromyalgia and other chronic pain conditions, migraine and headache conditions, GI disorders, and so much more. So many of us have developed so many of these conditions collectively that it significantly impacts, ADLs, and it makes, just fighting for yourself on top of being sick very hard. So when it comes to treatment, once again, just like we're bringing the research to our providers, we're also bringing that, here's the medications for this condition. Can you please learn a little bit more about this? Can we do a trial of this? And a lot of patients are confused about where to start. Where do I find this information? And again, this goes back to the lack of public education about long COVID. So like we have something called the Comprehensive Guide for COVID-19 Long Haulers and Providers. So it outlines these common conditions in long COVID. It outlines some of the tests to do, both imaging and blood work. It outlines some of the specialists you should be seeing, and it outlines some of the research that you should know about as a patient that can help you advocate for yourself. So if there's long haulers listening, you guys can go to longhauler-advocacy.org and go to our resources section. And we have a bunch of those types of resources for you, a list of COVID competent providers. So check that out, because this is really the only way long COVID patients are getting information. It's from the long COVID groups and organizations, which is why we're fighting so hard for more information coming from the top down so that it reaches more people who desperately need that information, which leads to them accessing treatment.
And then, yeah, just to wrap up, I think the last question is really the first, should should people be telling their employers about their long COVID? And I think, I asked that question, and I framed the panel around that is because, with fatigue, with, damage to the way that we're able to breathe, heart conditions, like this is really going to affect the way that people work. Say like here at the radio station, having your ability to breathe impaired is like, it's just like, that is just so central to your ability to do what we do. So like, should people be telling their employers about this in order for employers to, advocate on their behalf for healthcare coverage? Or is there possible that we might be setting up a situation where, maybe folks shouldn't know about these chronic diseases because like this is going to cost the healthcare system a lot of money, and there might be issues with covering it long term? I don't know if either of you want to sort of wrap up by answering that question.
I guess I could go.
Sure. Yeah, go for it.
I think again, it depends on the long hauler, their individual capabilities, the type of job they work, maybe the relationship that they have with their employer, right? So again, I'll speak from my perspective as a first responder, and from data we have in our organization is that 30 to 40% of long haulers are either first responders, healthcare workers, or educators, right? So these are three very physically demanding jobs, usually jobs where your health depends on you maintaining your job. So a lot of first responders and healthcare workers are afraid to come forward to their employers asking for restrictions or accommodations because it impacts their career and it could be career ending for them, right? But at the same time, due to their long COVID issues, it could actually cause harm to somebody that they're trying to help or treat. So there's an issue there. There's a moral and ethical issue there. And this is something that, the unions for first responders and healthcare workers and so on need to figure out and talk together about. But on the flip side of that, let's say you slip in your job performance and you're getting bad reviews at your job, or you get terminated. If you did not go to your employer and talk to them about needing accommodations or ask for some of that stuff, it may be very difficult to backpedal that. So when we talk about in the long COVID community, there's something in the MECFS community, stop, rest, peace. When you push yourself through some of this stuff, you make yourself worse. We go through what we call crashes or relapses. So that is going to affect your performance at your job. If you're constantly feeling even worse than your baseline because you're pushing through. If you can work with your employer to find accommodations that work for you so that you don't have to deal with that, so that you can try and stay more consistent, maybe it's a flex work schedule, maybe it's a work from home, both of which have been extremely helpful to so many long haulers throughout the pandemic. I can't tell you how many people say, if I had to actually go into work, I would be working 0%. In part of our poll where we had the 51% saying they were working part-time, they were reduced to part-time work. If they actually had to go into the workplace, that number would, 30% of that would probably jump over to the completely out of work category. So again, it's dependent on the long hauler, the type of job they do, the risks involved, and what you're finding as you're able to do as you navigate your illness through time. But there's times where you have to absolutely bring it up, and there's other times where if you don't, it could actually hurt you in the long run. So don't be afraid to ask for those accommodations. There's the JAN network, and long COVID is now covered under the ADA. So definitely long haulers, look into that, use that with your employers, and become familiar.
And Maanasa, any final comments about that question?
Yeah. I mean, I agree with what Karyn said about the, now that the ADA, they say that people with long COVID can be protected under the ADA. That's a huge step forward in a protection. And then you might be eligible for, reasonable accommodations. But as Karyn was saying, there's a lot of limitations to this because employers are not required to provide accommodations that create an undue hardship for them, or they excuse their employees from functions that they consider as essential for the job, and it's a very subjective determination overall. So there might be advantages, but then there's probably going to be drawbacks too. And like we mentioned earlier, employers also have the ability to lean on insurers to maybe get them to cover certain things so that their employees can continue to work and perform in the way that they want to, and getting them the care that they need. So there are some advantages to disclosing the illness to employers, but it's so specific to, again, like Karyn said, the job that you're doing and your relationship with your employer and their policies in general, and how many in the workforce have been affected by various COVID-related issues. And so it's a very case-by-case decision.
Yeah, there's a lot to chew on. I think, we're kind of underestimating how big of an issue I think this is going to be going forward. And by we, I mean collectively as a society. But I want to thank the two of you for coming to speak with us. This was really enlightening conversation. So yeah, Karyn, Maanasa, thank you. And then we're going to pivot to our second two panels, which are going to be hosted by WNYC healthcare reporter Caroline Lewis. She's doing two topics that I know are very important to her. The first session starting now is sustaining the healthcare workforce in the wake of COVID-19. And then starting around 3:15, session 3 is going to be facing the overdose epidemic. Where do we go from here? And Caroline, I give you the mic.
Awesome. Thank you, Nsikan. That first panel was extremely illuminating. And so now I'm going to get into the staffing panel first. So just so that everyone knows who should be on, it's Dr. Jean Moore, Heidi Siegfried, and Dr. Mitchell Katz. I'm going to introduce our panelists. So Dr. Mitchell Katz is president and CEO of NYC Health and Hospitals, which is the largest public health system in America with 11 hospitals and more than 70 outpatient clinics. And of course, Health and Hospitals has played a key role in the city's response to COVID-19. We're also joined by Heidi Siegfried, the Health Policy Director for the Center for Independence of the Disabled, New York, which strives to give agency to people with disabilities and protect their ability to remain in the community. Ms. Siegfried's advocacy work touches on both home health care and nursing homes. And her organization also runs New York's long-term care ombudsman program. And finally, we have Dr. Jean Moore, the director of the Center for Health Workforce Studies at SUNY Albany. And she can give us some of the big picture when it comes to challenges facing the health workforce in New York State. So I think, early in the pandemic, we had this sense that there was this sort of trial by fire for healthcare workers, especially frontline workers. Hospital workers were scrambling to help, try to help all the patients that were coming in with COVID. Nursing home workers were trying to help, all the people in nursing homes who were contracting COVID. And of course, we were, clapping for them every day. But I think that there are still a lot of ongoing challenges with the health workforce that are a little more hidden now. So I'd like to start by getting a sense of where we're at. And so I'll start with Dr. Katz. What are the biggest staffing challenges that you're currently facing within your health system, and how have they been shaped by the pandemic?
Well, thanks, Caroline, and thanks for the invitation, and I'm honored to be with the other panelists today.
Oh, I just, sorry, do you mind tilting your computer down a little just so we could see, or moving back a little so we can see you? Just want to make sure we can see your whole face.
How's that?
Much better, thank you.
Okay, very good, thank you.
Yeah, thank you for
well, Caroline, you I think painted the picture of how challenging the COVID has been for healthcare workers, and what I believe to be really a collective post-traumatic period where healthcare workers lived through a time where we worried we wouldn't have enough ventilators, where we lost not only our patients, but our family members and our colleagues, where whenever we came home, we worried about our clothing and whether or not we could be carrying the virus to our family members. I mean, it was a very scary, frightening time for healthcare workers who all went to work during a time when other people were able to stay at home, and lots of messages about staying home and protecting yourself. And then my healthcare workers are boarding the train and going to work, and often going to take care of people who had COVID early on, when we weren't even sure, which protective equipment worked. I mean, it was a very scary time, and I think it's had huge implications for our workforce. We are having right now a lot of trouble recruiting for our positions. And I think it's several things at once. There is a collective exhaustion, people who, did heroic work and are just exhausted and traumatized and emotionally devastated by that period of time that they worked through. We lost healthcare workers. People died, people got sick. People left the profession because they felt that the challenges were too great, or they felt that getting a vaccine would be harmful to them, and so they didn't want to get a vaccine, which is a requirement to be a healthcare worker in New York State. Some people discovered virtual work, and this has been an issue in the mental health field, especially, where we've had difficulty recruiting, for example, psychiatrists and psychologists who are doing excellent work, but they're doing their work by Zoom. And suddenly the idea of being on a hospital ward is less appealing to them. It's very difficult work. And then finally, I just say the demand is higher. We're seeing more drug use. We're seeing more severe mental illness, and a lot of people with pent-up health demands. So you have high demand and decreased ability for people to be able to respond to it. So all in all, a very difficult situation for us at this point.
Yeah, absolutely. And then Dr. Moore, I know that you have been surveying hospital administrators on staffing issues. So, are you hearing similar things, and are there other issues that are coming up?
Absolutely. So one of the things that, as Dr. Katz so eloquently described, there are some real serious issues around retaining workers who lived through a pretty traumatic time and say, okay, now I need to move on. So certainly that's part of it. And attrition from patient care or attrition from the professions themselves. But another issue is recruiting people into healthcare jobs. So we, as you point out, we've been surveying providers for a number of years, trying to understand who they have the most difficulty recruiting, retaining. Nurses are at the top of the list. But in addition, some other professions that perhaps we don't think as much about: rad techs, lab techs, social workers, respiratory therapists, surgical techs. In nursing homes, difficulty recruiting certified nurse aides, LPNs. In home care, it's home health aides. And so again, it's kind of a complex issue of how do we hang on to the people who are still in the workforce, and how do we bring people in? Another area that we're trying to pay attention to is understanding COVID impacts on the educational pipeline. So an interesting development is the fact that at the height of COVID, many nursing deans, for example, couldn't get students into clinical experiences because providers said, we just can't take students. You're going to have to figure this out. And they did. They used simulation as a way to get people through their programs and give them some of the skills they need. But one of the problems with that is a lot of new grads came out with much less direct patient care experience. So that resulted in many people coming into their first nursing jobs completely overwhelmed because they weren't as experienced with working with patients as prior cohorts were.
Yeah, and I know this is something that you had mentioned when we spoke, Dr. Moore, the idea of losing sort of institutional knowledge and people to train those, new grads, because people who have been in the workforce a long time are retiring early or leaving. Do either you or Dr. Katz want to talk to whether you're seeing that or what the challenges are?
So one of the things we've heard about, and this is from conversations with chief nursing officers around the city, is that they are developing nurse residency programs. And essentially it's an extended orientation to new graduates with mentors helping them through. But, one of the issues for these programs is that the preceptors are experienced nurses. And if you lose enough experienced nurses, these programs are in jeopardy.
Mm. And so I want to pivot a little. Ms. Siegfried, can you tell us a bit about some of the, staffing challenges that we were seeing in home care and nursing homes prior to the pandemic and sort of how they've been impacted? Has it become harder for someone to find a home health aide, for instance, or, how has the pandemic impacted patients' experiences in a nursing home?
So at Center for Independence of the Disabled in New York, we, independence, we are really trying to make sure that the services and care and policies are in place for people with disabilities to live independently in the community. But we do also have the long-term care ombuds program that serves people in nursing facilities to make sure their rights are protected. But the home care workforce, that has been a slowly developing crisis from before the pandemic. We used to say at one time that it was an upstate problem. It wasn't so much a downstate problem, but now in New York City, it's become more of a problem that people cannot, we try to get people out of nursing facilities, and they need to have adequate hours of home care to be able to live independently in the community. And usually that is a fight with, a managed care health plan to get the adequate hours of care. That was talked about in the previous panel, that you have to fight with the insurance company for everything. But say you do get adequate hours of care authorized, a lot of times the staff, the workforce is just not there to fill those hours. So we have people, it used to be that when you were in a nursing facility, the biggest problem was finding a place to live. The housing was the big issue. It has now become that having the home care is the big issue. And we have people that are in nursing facilities that can't get out because they don't, they can't get the home care in place. And it's not just the health plan, it's actually the workforce. So, we have tried to work on this past year by increasing the wages. Well, we worked on it for many years to try to increase the wages for home care workers. And we wanted to make sure that they would be getting at least 150% of the minimum wage, which in 2006 they were, but the wages have just eroded over the years. And now, they are getting less than the minimum wage in some areas, in the case of where there's a fast food wage that's higher than the regular minimum wage. So we feel though we did put some light on this issue. We got our New York State legislators to really know who people with disabilities and seniors are and why they need this care. And some of our legislators even went to the homes of people with disabilities to see what the home care workers did. I mean, it really was, we had a very good campaign this year, and what we ended up with was a $2 wage increase for this year, and then $1 increase for the following year. And we know this is not going to, end the workforce shortage, but the home care workforce shortage. But, we still feel like that was, a somewhat of a success. I don't think $17 an hour is going to work when Amazon is paying in their ununionized warehouses more than that. But it's to be continued. So that's that's the wages are a big part of it. I think also that we don't give the kind of respect and dignity to both the home care and the nursing facility workforce. It is actually a skill. It's not an unskilled occupation. Even the certified nurse aides in the nursing facilities, all of a sudden they decided they shouldn't have the 75 hours of training that they're supposed to get during the pandemic. And, we thought that, well, the National Guard could come in and do this work and, without knowing what they're doing. And it's important work, and we need to value it both, by respecting it and by paying for it. And even our governor said that. She just didn't really follow through. But, she said that at the beginning of the year. So yeah, it is a big issue. I will say another issue that is really coming to the fore right now about nursing facilities. And by the way, Dr. Katz didn't mention, but part of his system does include a few nursing facilities too. I worked with some of those residents. But the issue of safe staffing, which also got signed into law last year, and that's for both hospitals where it's to be negotiated just what it is, but for nursing facilities, a much weakened standard from the over 20-year-old standard that was in place was adopted. And I think that if certified nurse aides in nursing facilities had safe staffing standards in place, it also would contribute to the quality of their job. I think it would reduce the turnover. And in fact, there are studies that have shown that. So it's really unfortunate that New York adopted 3.5 hours of care split up between certified nurse aides and nurses and LPNs, instead of the 4.1 standard that has been in place, like I said, for over 20 years. But what's even more unfortunate is that the governor waived that standard, which was very scary, and that we really haven't seen an improvement in staffing since it did finally go into place on April 1st. So President Biden actually has also in February made this an issue, and they are at the federal level considering adopting safe staffing standards for nursing facilities, and so we're working on all fronts to improve conditions.
Yeah, no, thank you for laying all that out. I mean, I think just to get at sort of one of the key issues here. So you were mentioning that nursing homes are fighting the new requirements when it comes to safe staffing, and they were delayed by the governor, who said we were in the midst of a statewide health workforce shortage. And I think and you were talking about trying to recruit more home care staff as well. I think the question I have is, whether we're talking about long-term care or hospitals, is the answer just to pay more? Is that it? Do we need to raise wages? Is it just about the money, or what other sort of solutions can we look to? I'll start by going back to Dr. Katz.
Well, I mean, people deserve a fair wage, absolutely. But I would be the first to say it's not just about wages. And that's broadly speaking. If you ask people about their jobs and why people choose jobs and stay jobs, usually number one is, the mission, the satisfaction that they get from their job, the people that they work with. So I view salary as a necessary but insufficient quality in order to maintain workforce. I liked very much what Heidi said about respect. I mean, I think that one of the things that leads people to leave or not want to take jobs is the feeling that they're not respected. And you hear that not just from nurse assistants or home care workers, you hear that from registered nurses. You hear it even from primary care doctors who feel that the specialists talk down to them. The point is that you have to recognize everybody's contribution. Home care workers work hard. They're not registered nurses. You appreciate what they do, just like you appreciate what registered nurses do and what doctors do. And everybody has a role, and everybody should be appreciated for their contribution. I think that for several of these jobs, and the one I know best, because we're working so much on it, are the nursing series, is that it has to be a job people want. I mean, I think it's as simple as that. You, again, Heidi referenced, I think in very good ways, safe staffing. Nobody wants to go off to work in a hospital or skilled nursing facility and deliver bad care. Nobody wants to be part of an inadequate group of staff members, even if it's totally not your fault, even if you're running every second and doing everything possible for the patients or the residents. If you know that you don't have the support from the other professions, then it doesn't feel good. It feels like you're contributing to something that isn't really healing. So I think for all of these jobs, we have to look at them and ask ourselves, you know, what makes the job itself worthwhile? What are the things that matter to the individuals? I'm a big believer in mission, that people want to feel good about what they do. And one of the problems in healthcare has been the part of it that's been taken over by business, where, you know, money is the number one sort of goal. See more patients, generate more money, send more tests. And that just doesn't reverberate very well, especially if you're an underpaid healthcare worker and you're wondering why you're working so hard, you know, for a for-profit earning money, right? So I think trying to really tap into the mission that healthcare workers innately feel. People don't go into healthcare because they think it's a great way to make a lot of money. People go into healthcare because they're actually interested in taking care of people. So you should tap into that and figure out how people leave at the end of the day with enough money to cover their rent and food and expenses, but also the sense that, wow, that was a good day and I made a lot of people feel better.
Mm-hmm. Absolutely. And I want to just add to this, you know, I think thinking about long-term solutions, I just want to, because we're sort of running out of time, I want to bring in like an audience question that we got before the panel from Lauren Francis, who says, as a healthcare worker, I'm seeing a lot of burnout and the effects of the past 2 years on mental health of both coworkers and patients. Do you anticipate seeing greater mental health challenges, as well as so much grief in the coming years due to the past 2 years? And I think, like you guys have talked about, you know, we are seeing a lot of post-traumatic stress. We are seeing a lot of mental health issues. Like, so, you know, how do you actually address that? Like, what is the role of healthcare providers? You know, how do you deal with the burnout? Is there a place for like cultural changes in healthcare?
I think that worker resilience has become a greater priority for healthcare providers, because I think they're recognizing the impact of this stress on attrition from the bedside. So I think that's become important to them. And I also think they're doing other things like adding more support staff. So, you know, to Dr. Siegfried's point about, you know, safe staffing ratios, if you're not able to find kind of exactly what you need, you can build more support staff in a way that's going to relieve some of that stress. Another area is flexible hours. I think that there have been efforts to try and accommodate what staff really need, what's going to work for them given their other commitments. And I think employers are paying close attention. You know, one of the things I want to mention is that in talking to some human resources directors, they talk about generational differences in some of the candidates they're recruiting for jobs. And these candidates are saying work-life balance is a priority, and reflect on the fact that in some ways they're less mission-driven than older generations. And again, I think coming out of a pandemic, that is certainly understandable. Another area we didn't say anything about, but I really want to touch on, is the idea of career ladders. Why should somebody come into healthcare as a home health aide or a CNA and be dead-ended there? Why aren't we creating articulation to get people from CNA to LPN to RN to community health worker to case manager to social worker? You know, why aren't we building opportunities for upgrades? Because that's probably the thing we have over Amazon and Panera, et cetera, is creating opportunities for people to build careers. And it's clear that we need to do a better job of that.
Absolutely. So do either of you want to share closing thoughts, Dr. Katz or Ms. Siegfried, before we wrap up, in terms of like long-term solutions, or, you know, sort of building on that thought, or dealing with sort of the long-term mental health issues that we're seeing?
I love what Dr. Morris said. I think those are very practical solutions. Looking for ways to support people, career ladders, I think are a great idea. And the way, again, I always package this is it's mission, right? People know that if you have a job, you have to work those hours, right? You don't generally get paid unless you work the hours. So given that, most people by the end of the day, they want to feel good about it. Nobody wants to go to work, spend 8 hours, and then feel bad about it. People want to, when they leave, feel like they did something valuable. And especially in healthcare, where we don't come to it, we're not business people, we're not coming with the idea of either making something or making money. We're coming to care for people. And so at the end of the day, the mix of support staff, of good working conditions, needs to leave the person feeling, wow, I made a positive difference today. I feel good about that.
Absolutely. Well, you know, I mean, this is obviously a very short time to talk about a very big issue, but, you know, I look forward to continuing to cover it and speak with all of you. Thank you so much for joining us. I really appreciate it. Awesome. Thank you, guys. So I am moderating the next panel as well. So I'm just going to keep it moving along, I guess. And I'm going to invite my panelists to join for the drug overdose panel. It's about facing the drug overdose epidemic. So hold on one sec while I take a sip of water. Awesome. So on this panel, I'm joined by Dr. Sheila Vakaria, who is Deputy Director for the Department of Research and Academic Engagement for the Drug Policy Alliance, which is a national organization advocating for sensible drug policy reforms. And she's also worked with people with substance use disorder as a clinical social worker. I'm also joined with by Sam Rivera, who is the Executive Director of On Point NYC. And his organization operates overdose prevention centers in Harlem and Washington Heights, where people can use illegal drugs under staff supervision. Of course, they also provide a range of other services, but they were the first government-sanctioned supervised consumption spaces to open in the United States since they were authorized by New York City. And they've intervened in more than 300 overdoses so far. So to give a little context, you know, we're seeing data that show that the number of New Yorkers who died from overdoses reached a record high in 2020, and early figures show that 2021 could have been even worse. And of course, most of these deaths are from opioids. So a question for both panelists, to what extent do you think that this recent spike is related to trends that began prior to the pandemic, and to what extent has the pandemic sort of made things worse? Whoever wants to start.
I'm happy to jump in.
Absolutely.
If that's okay. So thank you again so much for hosting this very important panel on this really important issue. And I have to say it's a personal privilege of mine to be here with Sam, who is doing such incredible work here in New York City to save lives of our neighbors and our community members. One thing that I think has been getting lost in some of the broader messaging around the overdose crisis is that actually numbers started going up both in New York City and nationally in terms of overdose deaths like towards the end of the year in 2019. And a lot of our increases in overdose deaths predated COVID, but what we can say is that COVID for sure compounded a lot of the challenges that we were already facing before the pandemic and created new challenges as well. So in terms of some of the emerging and continued challenges that have persisted through COVID is the increasing unpredictability of our drug supply. For roughly 5 years now, a little over 5 years now, illicitly manufactured fentanyl has been mixed into opioid drug supplies, predominantly starting here on the East Coast, but has gradually also been moving towards the West Coast and broader, more nationally. And so the entering of illicitly manufactured fentanyl has created an unpredictable drug supply, which has posed a tremendous risk to people who would otherwise think that they were taking the right precautions by using quantities of opioids that they had otherwise developed a tolerance to. But I think that COVID has really laid bare so many social and structural challenges that have continued to be neglected, both at the state level, but also nationally. And in particular, I'm talking about the need for access to safe and secure housing, access to consistent and evidence-informed treatment, the ability to work and have a dignified life, and to be able to live on what it is that you bring home, which kind of touches on what the earlier panelists were just saying. And I think that COVID also laid bare some real challenges that we have in terms of our social safety net in terms of increasing isolation, increasing feelings of despair, a lot of feelings of hopelessness among folks, which oftentimes put them at risk for using, maybe even after not using in some time. So I'd say that some of these challenges have long predated COVID, but we know that COVID only exacerbated these challenges, compounded them, and then created new ones. But I'm happy to pass it on to Sam to speak more.
Yeah, Sam, are there like specific, issues that you've seen come up, during the pandemic that people are dealing with that may be exacerbating this situation?
Yes, definitely. I mean, for our people, it's a matter of, this was prior to us opening the OPCs. So people had very little access to anything during COVID. So we had to be extremely innovative and find our way to drop off whatever we could with our people. If we don't get them what they need, we watch chronic conditions increase around the city immediately, HIV or types of hepatitis. So it was also difficult to get them back out, right? Because, the other thing is most of our people are transient, so they don't have a steady place they stay. So if during COVID, when we wanted to keep them engaged, we even found ourselves bouncing around. We go to a place they were at for 2 weeks and then go back, and now the person's over here. And then we just basically didn't close. We had to keep our services open, at least, even if it was through the window. We weren't in a position to close. We just couldn't.
Yeah. And so to what extent did you see other services that people relied on close? And is that something that you feel like has, exacerbated the overdose situation? Is that something that's mostly been resolved at this point, or?
No, I think, we saw an increase in deaths because people there weren't many people out. And if you went through the city during COVID, it was strange for many of us. But people were using in different areas, right? There weren't many people out there. There weren't people out there to support them with Narcan if someone overdosed. Anywhere people could go without support was very challenging. For us, we always offered support in both of our facilities. And of course, since we opened the OPC, it's been very different. But yeah, having to be in this environment where almost everywhere they wanted to go was closed. Even certain medical services were closed. It was all about the ER while we're trying to get them out of the ER and try to get them to connect with a primary care physician. It all shifted. So people who we were engaging with well and getting them to avoid the ER and actually see folks at a different level. When you tried to go into a local healthcare provider, they were just testing people for COVID. Like that was it. Mm. So folks, especially for us, we also, offer Suboxone, and that was a challenge. We couldn't get anybody in. It was basically illegal at that point to provide services indoors. So we had many people, and then it was almost like, who's coming out of this? Like, who made it through? Who made it as we started to open? First chance we got, we opened. First chance, as soon as the city said you're allowed to open your site, we opened immediately. And then the fear and the pain was, who made it? Who made it through COVID? Who's still around? We're blessed to have an outreach and public safety team that goes into the parks and into the communities. And we just did this massive search. And we were blessed. We didn't lose many people. But we did see a lot of serious health conditions show up, and folks who were doing better really struggling with their health.
Yeah, absolutely. And so I want to encourage people to drop questions in the Q&A. Also, I should have mentioned that earlier in the last panel. So if anyone has questions, start thinking about them now. But just to orient people a little bit, I'm wondering if each of you can talk a bit about like what harm reduction means to you, and sort of like some examples. Not everyone is as familiar with the term.
Sheila, please.
Sure. So when I talk about harm reduction, I really talk about how most of the behaviors that we engage in and the choices that we make often come with trade-offs and with managing risks. Nothing we do in life is 100% risk-free. There are very few things that we can say are 100% safe. And when it comes to illicit drug use and substance use, oftentimes because we are so uninformed through our drug prevention education and our general public health measures, most of us are learning as we go when it comes to even our alcohol consumption, that we just kind of figure out how to stay safe. And oftentimes we're busy learning how to do it from our friends and loved ones who are lucky enough to survive and teach us these skills and strategies. And so harm reduction is a formalized way of recognizing how communities have always turned to one another for help, support, education, and resources on staying safe. And harm reduction itself was a term coined to talk about the ways in which people who used injection drugs did that to support one another, particularly marginalized ones who were unstably housed or not housed, who are facing structural racism, homophobia, heterosexism, transphobia. But when I talk about harm reduction, I talk about the ways that communities take care of each other and give each other the tools and resources to stay safe. So that can include access to sterile injecting equipment and sterile smoking equipment. It can include places like what Sam's running, an overdose prevention center. It can include learning tips for alternating, drinking alcohol and water, ways that we learn how to moderate and manage our use and cut down on our use. And developing strategies in our support networks to stay safe. So making sure that someone has naloxone, the overdose reversal medication on hand, making sure that someone is there to keep an eye out on us, and that we're with safe people who can respond and react if something goes wrong.
Absolutely. And I like that you included alcohol as well, because alcohol causes lots of deaths every year, and people think just because it's legal, it's not as dangerous perhaps.
Oh yeah. Wow, thank you for that, Sheila. That was great. That was really great. So I don't have to get into any of that stuff, which is wonderful. Sometimes people say the police car parked outside of the bar is harm reduction. It's like, oh, I drank. Let me make sure I get a cab today just because the police car is there. It's interesting. People participate in harm reduction all the time. Diet drinks, water versus juice, whatever it is. Seatbelts. You don't put on the seatbelt expecting to crash, but you put it on just in case harm exists. For me, harm reduction, in addition to what Sheila said, because that was absolutely excellent. You have to come visit soon, please. Is loving people who aren't loved, is showing up for people who are treated as other, who are not presented or addressed in the most respectful ways. People who have been dehumanized, people who are judged. Once you say harm reduction, it became this cloudy place where those people do bad things. And what I learned more and more, I just came up with my second year at On Point. Although I've been doing, harm reduction, participating in harm reduction for many, many years, what I learned more and more, especially since opening the safe consumption sites, is the love of people, of harm reductionists themselves are fighters, right? Because we've had to fight from the beginning. Can you imagine having to fight to keep your people alive, having to fight in the 90s to make sure to simply say sharing syringes kills people. Let's offer clean syringes. And it became this whole enabling thing. And people were dying every day while we were going through that. We're doing that today as well. We know OPCs work. We know safe consumption works. And what they want to talk about is the enabling or all of the negativity attached to it. So harm reduction is a place to realize harm exists. What do we do in the interim? It's not the answer, right? Harm reduction and recovery, harm reduction and treatment. We need to work together. Harm reduction and health. What does all this mean? Because what we know is people who are using drugs and using alcohol the way many people do are self-medicating pain, self-medicating traumatic experiences, and self-medicating mental health conditions. So if we allow them to be who they are and have access to a variety of services, then what we find is it's not about send them to treatment. It's about, wow, why did you stop using drugs? If you did, well, I started to see a doctor and felt better about myself. I started to participate in these groups and felt different about myself. I started to see myself as a human. And so harm reduction is where people land to be saved and stay alive until they decide it's time for them to move on from there. Because too many people believe as the provider that they stop someone from using drugs. And if you're one of them, please look at that or make a visit to your therapist because that's dangerous.
Yeah, I think that's something I've heard a lot when talking about overdose prevention centers with people who are not quite on board yet, are we just enabling drug use? Are we saying it's okay? What is their track record for getting people into treatment if they say that's the end goal? So just you touched on the enabling part and sort of responded to that a bit, but can you, either Sheila or Sam, do you want to talk a bit about what are some of the barriers to getting into treatment? Are there things you can do to sort of make that easier for people?
I'll start, Sheila, if you don't mind. I'm making my mom upset. You should go first. But so one of the hardest things is when we refer people, especially to outpatient treatment programs, not all of them, so to be easy, I don't want my phone to blow up, but oftentimes, too often, we refer someone and our people are active users. People want someone to show up to treatment really ready, how long have you been off already? And we get things like, well, your people are making other people want to relapse and your people are showing up like this, which is just absolutely mind-blowing for me. So there are those barriers, definitely those barriers. The other thing is there are some laws and some health laws because our people need multiple attempts. And it gets to a point where they had too many attempts this year. They have to wait till next year because insurance and things like that. So, and the other thing is really about having the person be ready. What too many people believe is that this is, drug use is a condition and we can fix that condition. And forgetting the core, the holistic person, right? You know, they go right to, oh, you're an addict. This is the condition. How do we break this from you? And don't spend enough time on oppression, on, you know, many factors. Women should be treated differently. Of course, does it happen? No, these programs are created for men by men and want women to fit in. And I'm glad we're breaking a lot of that, but it still exists. So the barriers are vary, you know, there are too many. And for us, what we see is, especially in the overdose prevention program, we're watching people at a booth at that moment who are engaging with other people in the room, feeling like a part of a community, who have said right there, you know, they push it away and say, I'm going to try detox right now. So our job is to jump on the phone and call our partners, which have been great, treatment providers and detox, places that offer detox, to connect them right away. So that's helped. It really has helped. We've changed the way we're working. Treatment providers and detox, you know, folks who provide detox services have changed as well.
That's awesome. Do you have anything to add?
Sure. I think one thing that we often presume is that there's enough of everything to go around. And actually there isn't. You know, there's about 16,000 treatment facilities for addiction that exist across the country that are publicly funded. And that's not even including the spa-like rehabs that people get to go to in Malibu when they have the money to do that sort of thing. And so we've kind of had a stable number of treatment facilities across the country for some time. And substance use disorder or addiction has also remained relatively stable nationally. But what we know is from year to year, about 90% of people with addictions don't receive treatment, partially because there are so few facilities, but partially because the number one reason that people don't seek treatment is because they're not ready to quit yet. The understanding in most treatment facilities is that your drug testing on day one as part of your enrollment is your last positive drug test. And I can say this because I used to work at one of these facilities. I used to drug test my clients pretty regularly. And the problem is that these facilities, whereas harm reduction starts where you're at, treatment facilities expect you to start where they're at. And they expect you to start on day one, committed to abstinence, changing your social network, being able to all of a sudden turn around and start showing up to treatment appointments and doing requirements, you know, several hours a week, regardless of your commitments. And they expect you to build your life around treatment. And so not only do we not have enough treatment facilities, but so much of how we operate treatment is on treatment's terms rather than the people who slip through the cracks. And what we know is that roughly 60% of all people who start treatment in any given year don't complete it. And it's non-compliance or inability to comply that's often a big factor, or being referred to an even more intensive level of care and not having the capacity to commit to that even more intensive level of care. And so I think where harm reduction fits in is this huge gap that is currently in our current system, where we've got outpatient treatment, detox, rehab, and residential treatment on one hand, but then we've got a whole vast number of people who have nowhere else to go for support. And harm reduction is here to fill that gap, but even what we can provide is so limited when our treatment facilities can't meet people where they're at. And so I'd say that those are kind of some of the additional challenges that I would add, but I feel like Sam really covered everything.
Yeah. So I'm seeing a question in the Q&A. I've been hearing more and more about how the war on drugs or fear of drugs is overblown and that most adults do not overdose, and the media's coverage of the war on drugs is making the crisis seem worse than it is. Curious to your guest's thought on that. As long as we're on the topic of the media, I also want to add that, like, you know, we see a lot now about fentanyl in the headlines and, like, you know, sort of how fentanyl is like the culprit. And of course, you guys have talked about how it's made things more unpredictable in the drug supply, but do you think that's like warranted all the sort of focus on fentanyl as well? Oh, sorry, I think you're muted.
Yep, I'm happy to take the first part of this question. If Sam wants to take the second part.
Sure.
So here's the thing, when we talk about the war on drugs, what we're actually talking about is the dramatic role of law enforcement and police in addressing what we consider our nation's drug issues. So when we talk about, is the war on drugs overblown? Are we overstating it? I would argue no. And what I mean by that is that out of all of the arrests that happen in the United States in any given year, that's about 10 million arrests that happen, 1.5 million or 15% of any arrests in the country are for drug issues. And that the vast majority of those drug-related arrests are for possession alone. So when I say that the war on drugs is real, it is the largest category of all arrests in the United States, and it's remained the largest category of arrests in the United States. And so to me, that is in and of itself evidence that we are currently in the midst of a war on drugs, and it's still unfolding in our lives. As long as people's first point of contact is a law enforcement officer because of their drug possession or their drug use, to me, that is a war on people who use drugs. And when people kind of talk about concerns about, are we also overblowing this overdose crisis? Overdose deaths in the United States reached their all-time peak in 2021, where we lost over 100,000 people to overdose deaths. If you think of the roots of this overdose crisis, which started around 1999, in the 20 plus years since the overdose crisis has started, we have lost over 1 million lives, and this number continues to go up. So also I would say that I would challenge anyone who thinks that we're overplaying the war on drugs, because I feel like the evidence is very clear, but I would also challenge anyone who says that we're overplaying the overdose crisis, because 100,000 lives lost in a year and over 1 million lost over 20 years, to me, also signifies a crisis. And I would say that because we as a society face a lot of challenges, you know, we've already crossed the 1 million threshold for COVID. I would say that sadly, we have developed a high tolerance for criminalization in the form of the way that we continue to arrest people. And sadly, our society has developed a high tolerance for death as well. But I think people like us need to continue to raise the alarm that none of these deaths are okay. None of these arrests are okay.
Absolutely.
Well, I was looking for that little reaction heart thing and clapping, and I couldn't find it. So that was great. You know, I say it, all of that in a sentence. There's no war on drugs, there's a war on drug users. I mean, that's really what it is. Are we overblowing this? Oh my God, no, we're doing quite the opposite. Here's what we have. We have fentanyl and everything, which we're testing heroin to see if there's heroin in it. It's just fentanyl. So while we've had this, you know, since we've been measuring and looking at overdose and having all these deaths, they're only increasing. Can you imagine? And we just had this, I think 2 weeks ago, a guy went into a Burger King bathroom to take a quick bump of cocaine. Well-dressed, working man, went in there to take a quick bump of cocaine to go back to work and relapsed and almost died. And is only alive because our staff happened, our outreach and public safety staff happened to be coming back to the office and went into Burger King to use the bathroom. So he went in to use a stimulant, had fentanyl, laid out, tongue out, blew, the staff saved his life. So, you know, it's not, in no way are we overblowing this. This is real. Fentanyl's cheap. It's in everything we're testing at this point. And you know, we see it in the room. We have a question on one of our forms. Did you intentionally buy fentanyl? And we had someone recently say, why do you ask that? Because there are some people who are trying to use fentanyl, but most people will even say, no, no way, right? No, no way, I wouldn't do that. But meanwhile, they're going to use fentanyl 2 minutes later. And so one of the other reasons we ask that is about the tolerance. It's about, you know, have you been, you know, are you aware that you're using fentanyl? So we have a serious crisis. Numbers, we're 2 years behind on numbers roughly about overdose deaths. And I think we expect those numbers to go up. They were definitely impacted by COVID, but unfortunately, it's anyone who has access to a drug. Don't forget, most drug users use in hiding. They're ashamed of it, right? They use in hiding, they use in a restroom, they use in an alley. We've seen famous folks who don't want anybody to know they're using alone at home and dying, and they didn't have to. What we know is no one has to die of an overdose. It's just a fact. We've had 324 overdose interventions in 6 months. 6 months in 2 programs. Don't forget it as well. I want to remind folks, the city wanted to open 4 4 programs and have 130 interventions. We have 2 programs, 6 months, 324. This overdose crisis is real. The war on drugs isn't. The war on drug users is. People celebrate watching a show when they catch somebody getting off a plane with a kilo of heroin, like they saved the day. That's not the issue. Drugs are coming in truckloads, not by someone flying in from another country.
Yeah, and I think, unfortunately, I wanted to touch more on sort of like addressing issues with the drug supply, but I think that's like way too much to tackle in the last couple minutes. So I'm just gonna bring in another question that we received from the audience. This was submitted beforehand from Rachel Fowell, who says, what should we be planning for in public libraries or in public buildings like libraries? We already have Narcan and have reversed over 40 overdoses at my library.
Incredible. I applaud you and your team for doing this incredible work and being at the front lines. I think that that is incredible and admirable, and it goes to show that people don't want to use alone, but people are forced to often try to find any place that they can be so that if something were to happen, someone would be there to respond. And I'm so grateful to hear that folks at the library are there to respond. I think that, in addition to having naloxone on hand, I think that, if there's also a way to put up any sort of flyers or other materials and brochures, the New York City Department of Health and Hygiene has developed an incredible number of flyers and resources and brochures that can help make sure that people know where they can go to get help or get support, and perhaps to get directions to go see Sam and folks who are running that center. But I think the other thing that we don't talk enough about is the importance of regular everyday citizens kind of conveying to our elected officials and to our politicians that, we're all at the front lines of this overdose crisis. And I don't know where your neighborhood is, but I think you need to let your council folks know that if you don't live in the same jurisdiction as where Sam's working, that your community needs an overdose prevention center, but that also that people in your community need access to information and resources to help keep each other safe. And it's possible that a lot of these folks also are unstable and not receiving help and services. And there's a lot of really excellent and innovative models of libraries that have hired peer workers, that have hired case managers, that bring in social workers and other trained staff to be there to be a resource. And I think that would also be a really great thing to do. But thank you for already what you're doing. And we need folks like you.
Absolutely. Before we wrap up, Sam, is there anything that you wanted to add?
No, that was perfect. That was absolutely I was going to say the signs and everything else. Just bless you for having Narcan. Bless you for understanding that people are going to use where they can. And I love the idea of trying to get them to us, without judgment. We know that bathroom programs have started simply by someone saying something like, oh, where's your restroom? And then say, do you happen to have Narcan? I'm just wondering. And it's like enough of a sign like, oh, right? And instead of preventing them from using a restroom, being prepared. So bless you at the library for having it on hand. And Sheila broke it down perfectly.
Awesome. Thank you guys so much for being here. I appreciated how much love there was between the panelists in this session. And so, I really appreciate it. And thank you to all of our panelists today. This has been a really amazing health convening. I'm going to turn it back over to Nsikan before we close out.
Hey, thank you. Thanks, Caroline, for hosting those 2 excellent panels. I feel like I learned a lot. I'm sure you now have a bunch of leads for stories. I want to thank Sloan and Robert Wood Johnson for supporting the WNYC Health Convening in our health coverage. Also, I want to thank the whole squad behind the scenes who helped us put this on. We're going to post a recording of this event to our YouTube pages. In close, I think we as New Yorkers or New Jerseyites or Americans or whatever, we are all ready to move beyond COVID, but COVID isn't over. Its pandemic phase isn't even over. I can't emphasize enough that this virus continues to create irreversible changes to the day-to-day lives of millions of people whether we're talking about long COVID and healthcare coverage, or the overtaxed medical workforce, or how the pandemic has exacerbated substance use, or how to tackle it with harm reduction. So, there's a lot more to get through, and I think we can do it through conversations like these. So thanks to everyone who came, and to all of our panelists, and until next year, see you.